All right, so my talk is on deep hypothermia circulatory arrest, perfusing and protecting specifically the brain. All right, now you have the whole body to be concerned about, and I'll discuss that a little bit, but really I'm focusing on the brain. What are the indications? Well, deep hypothermia is most commonly used in elective complex aortic arch surgery where it is impossible to perfuse the brain through cerebral vessels using a standard CPB cannulation technique. DHCA, or deep hypothermia circulatory arrest, is also commonly employed in acute type A aortic dissections. And these are typically emergencies. These are typically cases we enjoy them when they're over and they're successful, but we dread them. Getting that call usually at 10 or 11 o'clock at night is usually when it occurs. So these are my old slides. Can you put up my new slides? These aren't the ones I sent you. Okay. Hey, everybody, can we take a 2-minute break? John, we can just talk while they pull up the right slides because it's not the right slide deck. Sorry for that delay. Let's see. So John, how's the weather down in Orlando?
You know, today we have a cold front.
Yeah, that's not it.
It's really strange. And we usually don't have cold snaps come through this time of year. Yeah, very strange. This morning it was probably in the low 60s, which to us is cold.
Really? What's the temperature? Let me see what the third slide on that looks like. Or you have to go to WeTransfer and look.
Well, it's funny what you were saying because that type A dissection, there's never a good time to hear that.
No, there never is.
There's never a good time to hear that.
Never a good time to hear it. Never.
No.
Nope. Nope.
That's when your heart just sinks when you get that call.
That's it. Now we got him. Yeah, I remember the worst day of my life. We did 3 of them in a row.
Wow.
And it was excruciatingly painful. And it started on a Friday early evening and then kept on going all the way until Saturday late at night. And I joked with the surgeon. I called up and said that because it was the emergency room, and that they had another one, and he just was beside himself. And of course I was too, but I was making it up. I had somebody call from outside the room, and I was like, well, it's not really April's Fools. Man, he was mad. He was hot. He was hot. Okay, let me go back to my slides here. Okay, so this is the CT that you get, and you look at it and you go, I know this is not going to be a good day. And in this case, you actually have a left main dissection as the entrant point. So that's a really bad one, you know, because now you've got to deal with that as well. But frequently it is above the aortic valve, and you can just replace that ascending section of the aorta. And this is kind of a diagrammatic representation of what you saw in that CT of being the true lumen and the false lumen, and seeing the flap, and you see the line that's sort of separating the two, and it gives you an idea of what it looks like from a diagrammatic perspective. And this is the horrible on the left, what you see, and you see all of the blood that's in the false lumen. It's dark and it's probably clotted by now, and it's really bad. And a lot of times with these patients, you open the pericardium up and you see blood in there too. But then on the right side, you see obviously what is the repair and so forth. So, you know, and that's to people that do this for a living, that makes a lot of sense. To people who don't do this for a living, they really don't know what they're looking at. But when you see that on the left, you know, there's a high pucker factor associated with that. So I wanted to put this diagram up because I think it really helps to illustrate why doing these kinds of cases are so difficult. And I took this diagram from online, And if you look, you'll notice that the heart is kind of missing, right? There's the superior vena cava, the inferior vena cava. You don't see the heart. And there's the aorta right there. So in normal bypass, the aortic cannula is put in somewhere in the aorta around here, just above the heart, and it perfuses the head vessels, and it perfuses down the body into all the organs and all that kind of stuff. But now they're going to cannulate down here in the femoral artery, and they're going to come up here and they're going to cut this part of the aorta off. And then they're going to cut the part of the aorta off that has where the dissection started. So between the aortic valve and this spot, it's going to be wide open. Well, there's no access to clamp here. And if you did, your femoral artery is only going to still just perfuse up to that point, and you still have to worry about the head. And so if you see the arch vessels, there's the innominate, and you have the right carotid, and then you have the left carotid coming up over here. But I really want you to take note of how you have the jugular vein coming down and intersecting into this. And all of these vessels are connected way up here in the head by the capillary system. Now we think about it, we give antegrade and retrograde cardioplegia all of the time. If you have multi-vessel disease with tight lesions, giving antegrade cardioplegia doesn't do you a lot of good because you can't get the cardioplegia distributed. So you need to give it retrograde. When you do aortic valves, if you want to do, you either have to use direct coronary perfusers or you can give it retrograde, and you actually see the cardioplegia coming out of the coronary sinuses. So perfusing retrograde will work in the heart. It will also work in the brain. So if it's going up the normal circulation, up the aorta and through the arterial system, it's antegrade. If it's going up the retrograde direction through the venous system, it will make its way through the brain and come back, draining back to the arterial system. So I just wanted to, even though it's very rudimentary for a lot of my colleagues, I still wanted to point that out because I think this diagram really explains very well what it is we're trying to do. So what are the other indications? Well, congenital aortic arch surgery, patients that have, let's say it's a porcelain aorta. Pulmonary thromboendarterectomy is very common, and that's a big operation requiring deep hypothermia circulatory arrest. Tumors invading the vena cava, especially renal cell carcinoma tumors, can be a real difficult thing to clear out without circulatory arrest. Complex AV malformations, gigantic cerebral aneurysms, and surgery to head and neck vessels. So there's various different reasons, but my focus is really on type 1 dissections because those are the cases, because most of the time, if you're going to get a case, you're not going to do a procedure that is planned from a congenital deformity or something like that at a community hospital. They're going to go to a medical center or be referred to one that does aortic surgery all the time. What you're going to get are type 1 dissections. That's what you're going to get. So what is the conduct of perfusion for deep hypothermia circulatory arrest? You got to do a really good pre-op assessment. You want to figure out your cannulation strategy. For CPB, femoral arterial return and a standard venous, or do you want to use a VFEM type of thing and do a femoral venous cannulation? Either one will work and work fine. I prefer they put just a big right atrial IVC cannula, double basketed system, or a two-port drain system to really get good drainage because I don't want the heart stuffed at any time, and then add an extra SVC line. I like a 22 French, and you have to make sure, and I'll show it to you later, where they put tapes around it. And we'll talk about that a little bit. Or if you're going to do antegrade, then you put a graft to the axillary artery. Now, I don't like antegrade. I prefer retrograde, and I'm going to try to make a case for that during this presentation. Also, temperature management is of utmost importance. It has to be at least 2 sites. I personally prefer the bladder and esophageal But you can use the rectal, you can use the nasopharyngeal, but I strongly discourage nasopharyngeal. That's why I put a line through it, because I think that can be altered and be inaccurate based on a lot of other factors, including ambient air and other factors like that. I just don't think it's deep enough. So cooling and arrest. Venous return and arterial outflow gradient should not exceed 10 degrees centigrade. Packing the head in ice or using a head cooling device, they have those, is also very helpful to keep from convectively warming it up, depending on the room temperature and what's going on at the time. Use of neuroprotective pharmacologic agents need to be given before circulatory arrest for obvious reasons. You can't circulate it if you're on circ arrest. So you really need to make sure you time these things properly. And cooling shouldn't be done in a hurry. Cooling should take time because you want to make sure you get very even cooling of the brain and the surrounding tissue, which will eventually start to distribute heat back into the brain where you don't want it to be. So having that brain really at the right temperature is going to make an enormous difference. Some of the pharmacological neuroprotective strategies that we have are, of course, sodium pentothal or thiopental decreases cerebral blood flow, however. It has myocardial depressive effect, and it can be responsible for delayed wakening. So you have to remember that. Now, it will lower the cerebral metabolic rate for oxygen significantly, just like propofol will, but it has those other side effects. It does decrease CBF. So does propofol. It also decreases cerebral blood flow. But the evidence as to whether these pharmacologic adjuncts to cerebral protection actually work is lacking. And so you have to sort of use your judgment there. I think it still makes sense, but I like the old sodium pentothal. It worked. We had very good success with it. When you use corticosteroids to control inflammation, which it does very well, you have much more difficulty with glycemic control because it causes the blood sugar to go up. Volatile agents, such as what we talked about yesterday with the desflurane and your anesthetic gas on the pump, those actually decrease the cerebral metabolic rate for oxygen. So those are very good for neuroprotection, your volatile anesthetics. They decrease the CMRO2. So let's take a look at these in a little more depth if we can. Cerebral blood flow, so volatile agents, cause a dose-dependent increase in CBF due to vasodilatation, and that's going to include all of the thanes, halothane, desflurane, isoflurane, and sevoflurane, okay? Your cerebral metabolic rate for oxygen with volatile anesthetics decrease, and you will have luxurious perfusion, a state where cerebral blood flow is greater than the requirement. The exception to this, very important, is nitrous oxide because it leads to an increased cerebral blood flow, but also an increased O2 requirement for the brain. IV anesthetics, they will decrease cerebral blood flow. They will decrease cerebral metabolic rate. They, with the exception of ketamine, that increases cerebral blood flow and increases the cerebral metabolic rate for oxygen. Benzos, you can read that there. Opioids, essentially no effect. And non-depolarizing neuromuscular blockades, you can also see there what's going on there. Succinylcholine, it says, is controversial, and I don't know too many people that still use sucks. So what is the optimal temperature and duration of deep hypothermia circulatory arrest? Well, really when you take all of the information that's out there, between 18 and 20 degrees Celsius is considered optimal. And this is derived from looking at all the studies that I was able to find, and also all my own experience. Studies on pigs have shown that even at a core temperature of 8 degrees Celsius, however, cerebral metabolic rate for oxygen still remains at 8 to 11% baseline. That's very impressive. And I do believe that holds true for humans. Despite isoelectric EEG, oxygen consumption still occurs. Analysis of the data at 18 to 20 degrees Celsius, 40 minutes is probably safe. And that's a big probably. I've done probably, I don't know, I've done a few hundred type A dissections or type 1 dissections in my career. And of the ones that did well, they all had retrograde cerebral perfusion. Of the ones that did not do well, all of those were done without selective cerebral perfusion, just clamp and go. So I come from a time when that was something that would happen, and even at 18 degrees, the outcomes were still not great. So I am, even though it says 40 minutes is probably safe, at 30 minutes, what does safe really mean? And the outcomes were never good. The only time it's ever been really effective and where I feel like the outcomes were consistent with what we expect the patient to do well, 18 degrees is what I like to be at, and I like to have adjunct isolated cerebral perfusion, preferably retrograde, which I've said 1,000 times, I know. Beyond 40 minutes, the incidence of stroke and neurologic deficit markedly rise. And I'm sure there's injury occurring even before that. So this is a very good slide. If you look at the blue line, let's see if I can get this to work. Yeah, I'll just talk about it. So if you look at the cerebral metabolic rate at 100% of baseline, and you look at the temperature straight down, you see it's 35 to 37 degrees, somewhere around there. There it goes. There it goes. That's working now. So right there. There you go. So there's your 100% at that temperature right there. And then you watch as the temperature decreases going from right to left, and you see your cerebral metabolic rate decreasing as the temperature goes down. But you never see it. There's nothing that's going to take it to zero. And you look over here at the safe HCA time, as your temperature is increasing going from left to right, and there's your time on this side, you see it's going down, 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 down. So these are very important. This is a very important graph to have, and there are documented actual numbers that you can use and have. In fact, we have an app that's going to be coming out soon that's going to have actual temperatures of safe circulatory arrest time. Now, these times, keep in mind, are assuming no adjunctive selective cerebral perfusion. Again, I would want to go someplace that was going to try to perfuse my brain selectively. They're laughing over there. Thanks. Selectively if I had a type A dissection. So glucose and hematocrit management on these cases. Hyperglycemia is associated with poorer outcomes, and that's even on heart cases. We know that. Uncontrolled hyperglycemia is bad. Hyperglycemia is common during deep hypothermia. CPB-induced inflammatory mediators mediate insulin resistance. Hypothermia results in a decrease in the release of insulin. So you get a decreased release and a resistance that is secondary to the inflammatory process that takes place. Corticosteroids, as I said earlier, commonly we use them for neuroprotection, further exacerbate this hyperglycemia. So we use them for inflammatory mediator mitigation and neuroprotective maneuvers, and of course it further makes managing hyperglycemia more difficult. We should have them on an insulin drip, insulin pump, and keep their glucoses below 100 milligrams per deciliter. That's the data from the textbooks and various different articles. Hematocrit and blood viscosity during DHCA. When the blood temperature is decreased, this is a fascinating fact, is decreased from 36.5 to 22 degrees C, blood viscosity increases by 26.13%. According to Poisson equation, we all know Poisson from perfusion school, of course, the blood flow rate decreases 20.72%. There's a 35% decrease in erythrocyte deformability. Remember, it has to get through the capillaries, and the capillaries are 5 microns, the red blood cells are 7 microns, they got to squeeze through, so they can't squeeze through if they won't deform. Kind of the same thing you see with old blood from the blood bank. And about 19% increase in plasma viscosity. And these things will result in microcirculatory perfusion derangements, deficits, whatever you want to call it. I would love to use my dark field side stream scanner on some deep hypothermia cases to see what happens to the microcirculation as we're cooling the patient. I haven't had the opportunity to do it yet, but that would be an incredibly fascinating study to do if I had an animal lab. Somebody out there watching has the idea of using a microvascular camera and has an animal lab that can do this, I will come to you and we can do this. Just share the imaging with me so that I can do a program on it, or come on the program and do it yourself. So what about neurologic monitoring? We do that too. Well, there's the EEG, we're kind of used to that, and then there's the somatosensory evoked potentials. There's those 2 different kinds. There's oximetry, which you can measure the jugular bulb or jugular venous bulb oxygen saturation, which is kind of like the Rivers catheter that is in the superior vena cava, as just above the abdominate. And it measures the saturation of the venous return saturation coming from the top of the body, which just uses more oxygen. And in some centers, depth of anesthesia monitoring could use the BIS monitoring, but it's unclear how to interpret these values in the context of DHCA. I don't think the BIS monitor, I think it's very good for knowing if your patient is under anesthesia and under a certain number where the likelihood of having any kind of awareness or recall is diminished to a point of acceptability. For this, I don't think the BIS monitor makes any sense given how the BIS monitor works. But what are the advantages and limitations? Well, EEG, you can read the advantages and you can read the disadvantages. The somatosensory evoked potential, you can see its advantages and its disadvantages. The jugular bulb, SJO2, that's kind of makes sense because if you use retrograde cerebral perfusion, it's going to be great. But I think it would be a good tool for standard cardiopulmonary bypass to know what your upper body SVO2 was. And then you have NIRS, of course, which is what do you call it? What do you call that thing, John? Do you remember? They have several of them out there.
It's the infrared spectroscopy, but they have the foresight.
Yeah, there's foresight.
The other one is called the NIRS, isn't it?
No, I don't know. I don't remember. There's foresight and something else, CASMED or something. I don't know. But nevertheless, you have those. But those are going to be, I think they're going to have, besides the limitations that they point out, I just don't think we can say it's really measuring brain saturation, and therefore, if you have it, I think you have to consider the values, but I think that you have to consider the values with some level of skepticism and validate it with other things. I think if you have a gross imbalance from a baseline, I think you need to make an adjustment, but to rely on it independently and solely, I'm uncomfortable with. So acid-base management, this is going to be John's area of expertise. I just want to point out that when you go to deep hypothermia circulatory arrest, there are things that occur, especially with the PCO2, that result in some either vasodilatation or vasoconstriction of the cerebral circulation. And so you can see here the ABG is corrected for the patient's temperature, or the ABG is not temperature corrected. Basically, the two things, the difference between pH stat and alpha stat. But John is going to go into it in much more depth, so I'm going to breeze right over it. Now, here is an example, and it's a very good diagram. And if you look here, you can see that they're cannulated via the subclavian artery or axillary artery, and the flow is coming like this. They have a clamp here, so it's going up into the brain, and they are relying on the circle of Willis to reconnect it to the contralateral side and then drain down through what would be then the left carotid. That's what they're attempting to do in this configuration, okay? In this configuration, what you see is the blood is being perfused up the, there it is, up the IJ, up the SVC and the jugular. It's perfusing the brain in a retrograde fashion and then draining back through what would be the right carotid and then joining up with the innominate, and then also from the left carotid and coming down and joining up on the island that has been removed here. So they call this the island, where you have the arch vessels and they've transected it off of the native aorta. And so when you do retrograde, you actually can see this blood returning. And a lot of times you will see a not insignificant color differential, meaning that oxygen is definitely getting extracted from up there in this brain that is 18 degrees. It's also a question of, should you keep your temperature while you're perfusing retrograde, keep your heater cooler on at 18 degrees? Of course, I believe, yes, of course you should. You should keep that brain as cold as possible. Then the question is, should you keep your volatile anesthetics on? Probably not going to need them for anesthesia purposes, but because of the positive influence it has on cerebral blood flow and cerebral metabolic rate for oxygen, I would think you would want to. So that's a good question. I couldn't find the definitive answer to that, but commonsensically, it tells, I believe you should. So this is a diagram of what we typically see with a more exotic approach, where you're perfusing all of the arch, or you're not perfusing the innominate, I'm sorry, you're perfusing the left carotid. No, yeah, that would be, let me see here, hold on. I guess that's the left carotid and subclavian, John. That's what it looks like to me, but because that's going to get the vertebral. But it doesn't look like they're doing anything with the innominate there. They're just yeah, they are. They're perfusing it through. Yeah, I see it now. Okay, so here they're perfusing it right here through the subclavian. It's coming into the innominate up, and this is gonna be going. This is now the right carotid. Then this is the left carotid, and this is the left subclavian. And it's going up the left subclavian because the vertebrals come off of the subclavian and go up to the head. I'll show you a diagram of that later. So perfusing the vertebrals is very important. You can have a pretty big stroke when you're not perfusing those.
Hey, Joe.
And I think, yeah.
Can you hear me?
Yeah.
Yeah, so, about 40% of people do not have a complete circle of Willis.
I'm getting there. I'm getting there, but thank you. I was getting there. And here's another picture, another representation of a more exotic cannulation technique. It's pretty dramatic. These are planned cases, just so you know. These are planned cases. This one here and this one here. You don't just do this you know, if you're in the community hospital and you do 200 hearts a year and somebody just rolled in with a type 1 dissection that can't be transferred and you have to do it. You're not going to do this. I wouldn't recommend it. There's too many other easy ways to do it that are highly effective. These are for really big planned aortic surgeries by highly trained people, and especially the perfusionist. That's a lot of circuitry to really try to keep track of and know what's flowing what with what pressure and what's appropriate. I wouldn't want to do it. So here is an image of the brain and the circle of Willis, which John just pointed out. And it's sort of, you know, wraps around the head, obviously, and it's laid out flat, just to give you an idea of what it is they're depending on. So you can see the blood would come up one of the carotid arteries, then it would go into the anterior communicating artery, over to the other side and around, and you can sort of figure this out in your head, how that all kind of goes in a big circle. And one would hope that that would be good enough. Here's another example of it and kind of what it looks like, just to give you an idea. I think it shows, too, the vertebrals coming off the subclavians very nicely there, very clearly, essentially perfusing your basilar artery. And so you would essentially eliminate basilar artery flow in some of those other models, were it not for the circle of Willis, or possibly, maybe not. John? So here is the information that John just alluded to. So they took these cadavers and they chopped them up and looked at their brains, and basically kind of getting to the bottom line here, 46% of people had an incomplete, and by incomplete, it means that the arteries communicating across, these communicating arteries, were too small in diameter to have significant or appreciable flow. And that was really the issue. So when we say an incomplete circle of Willis, it really is referring to the diameter of the blood vessels that are communicating the two halves together are just simply too diminutive in size to be effective. And with that said, they talk about contralateral perfusion to the brain seems to be good for most patients undergoing operations of the aortic arch. However, additional means of brain protection are still needed. This is a very important article that anyone that does antegrade cerebral perfusion needs to look at and consider when they are confronted with this type of a patient and situation. This is an article by Dr. Estrella. He was with Dr. Safi. He does of course, Dr. Safi is a giant in the field of aortic surgery, and Dr. Estrella trained with him or under him and became his protege and really has mastered that craft as well. So he does a lot. And this is what they do here at the Texas Medical Center at Memorial Hermann UT. They use retrograde cerebral perfusion preferentially, and they have incredibly good outcomes. And I guess my view is, if it ain't broke, don't fix it. That's how I'm going to say about that. So here's an example of a system, and if you look here, you have the reservoir draining the blood from the patient. And you look up here, coming out, coming down. It goes into the pump, into the membrane oxygenator, comes out, and if it were going to be going back to the femoral artery, it would go this way and like this. But we clamped it here, so it would follow this additional circuit, go up here, go into the venous system and the IJ. So this is a method for performing retrograde cerebral perfusion. It's a system, not the system I like. I'm going to show you the system I like. It's a lot, in my view, it's a lot more simple. And then you see the blood represented by this blue, because normally, of course, in the normal circulation, it's red going that way. You see it as blue coming this way. And when they are having these things transected, you can actually watch that blood coming through these vessels, which is very helpful. So this is what I prefer. This came out of, this was in 2003. And it's a system, I don't think I got my system from them because I think I was doing it this way before. But what I do is I take my arterial line and it goes into the femoral artery, and I create a bridge between it and my venous. Here's my bicaval venous drainage right here. This shows a bicaval. I like to use just a regular single so you really have good drainage. But your venous line is normally coming down like this and going to your reservoir to the pump right here. But so if I put a clamp here and I put a clamp here and the surgeon puts a clamp here, then my flow is going to be going like this out of the arterial into the venous, like this, and right up the superior vena cava to the brain. And that for me is the most simple approach towards doing this. Now with the caveat, I flip this connector. I actually have it facing the other way so that this blood doesn't have to make that right angle. Probably doesn't make any difference because the flows are pretty low, but I do flip it, but that's just my way of doing it. So cerebral perfusion opening pressure. When you do antegrade or retrograde, either one, you have to have enough flow and pressure to get the cerebral vascular system to open up and start being perfused. And I'm going to say this now, but I'm going to say it again later. If you have TCD, it makes doing these operations a whole lot easier because you can actually see the middle cerebral artery and know whether or not you have good flow, okay? So you need it to have an evenly distributed perfusion to the brain. Normal brain blood flow is between 700 and 900 mLs, or 50 to 55 mLs per 100 grams of brain matter, and the brain weighs about 1,300 grams on average, or it's 15% of your cardiac output. So you can figure it out from all of that. When we first go on, I like to drive the pressure up to between 60 and 70. And remember that this is transitioning back to native circulatory flow patterns. So you have to remember that. Maintain it at about 40 to 50. Now some say 25, but the cases that I've done, and I've done a couple of hundred of them, and of the last, let's say 50 that I did, I kept the pressure between 40 and 50 with a flow rate of about 400 to 500 milliliters per minute. I was able to easily visualize the blood coming back through the arch vessels, and it was really pronounced. It's real obvious that you have flow. Again, I do think TCD would be an extremely valuable tool. I wish we used it more frequently. I wish it was more available to us. I wish it was more common. I wish that there wasn't so many turf wars up at the head of the table. I wish it was just something we accepted to do, kind of like doing, putting an ET tube in somebody that's going to be under general anesthesia. I do believe luxurious flow is better to a point. I think you can be excessively luxurious and end up with a lot of edema. I think you need to be really careful about maintaining your osmotic pressure, your oncotic pressure, your electrolytes, your PCO2. You really, when you go on cerebral perfusion, you're on circ arrest and you're on selective cerebral perfusion, you still need to monitor your blood gases. You still need to look at what's going on with your electrolytes and your metabolites in that blood, because that is what is going straight to the brain. Monitor gases, acid-base status, cerebral perfusate, maintain normal physiologic balance, and that's very important. You want to keep the COP normal. You do not want the brain to be being perfused with a grossly hypotonic, or not hypotonic, rather, hypooncotic fluid that is going to third space into the brain and cause a lot of brain edema. So you've really got to be cognizant and cautious of that. Rewarming. Rewarming after completion of the portion of the surgery that requires deep hypothermia, and they time this so that they're able to do the distal anastomosis first, and then what they'll do is fill that and clamp it with enough length that they can do the proximal, and then you can go back on native circulation and start very slowly your rewarming process. And then they do the proximal portion of the anastomosis just under normal normal perfusion. So that's how they time these things out. This is, though, very important. You need to maintain your temperature where you had it, like 18 degrees, when you return to native circulation for about 10 minutes so that you can reperfuse the CNS. That's very, very important. If you don't do that, then you're going to have this great temperature differential that's going to jump up real fast over here, and you're going to have a problem over there, and you're not going to want that to happen. Maintain your arteriovenous temperature gradient at less than 10 degrees centigrade. Warming must be slow and usually limited to a half a degree per every 2 minutes. Rewarming times of 90 minutes should be expected. You do a type 1 dissection, you do a brilliant operation, you had a great perfusion run, and you rush warming the patient because everybody wants to get out of the room, and the patient has a stroke because you rewarmed them too fast. What the heck have you done? You got to take your time. Don't exceed a blood temperature of 36.5 degrees. It will severely exacerbate any neurologic injury that may have occurred from embolization, from whether it be particulate or air, or from just a bad distribution of flow to just one area of the brain. So you want to be very careful about how you rewarm the patient and not go over 36.5 degrees. And also plan to aggressively treat hypothermic-induced coagulopathy. Now, I'll tell you, back in the days of Trasolol, we did these cases, they were chip dry. Trasolol really did work. But of course we don't have it anymore, so it's really kind of a moot point. But I've done them even without a protein or Trasolol, and have not had, and have done many cases where if you get them tuned up right, you know, we might have had to transfuse some clotting factors, but really gross, profound hypothermic-induced coagulopathy, if you take your time rewarming, if you use a good system, if you use hemoconcentration, if you make sure that your numbers look good, your albumin levels are good, if you do need to add a little bit of blood or a little bit of plasma, that's fine. You should be fine. If your anastomosis is good, should do fine. If tissue's not edematous, they should do fine. You know, because of course the surgeon, I'm sure, there's no way an anastomosis leaks when a surgeon does that operation, right, John? Never. It's never the proline's fault.
Not that I've ever seen.
Correct, right. Something else. They handed him the wrong suture. Something happened. Your pressure was too high. There's a reason it happened. So with that said, I think if you really tune these patients up, they do remarkably well after these operations. As long as, again, there's integrity of the anastomoses, they have their fluid volume distribution is normal, you don't have them edematous, you've given them really good brain protection with hypothermia, pharmacologic agents, and you have minimized the inflammatory mediators through hemoconcentration and just good technique, kept their oxygen delivery to their brain, rewarmed them slowly, took your time. You know, it's very rewarding when somebody comes in who's 52 years old, who shouldn't die, and they have this horrible type 1 dissection, and they leave the hospital back home with their families. It is a very rewarding portion of this job, because those are big cases. They're dreaded cases, but they're the cases when they're over and the outcome's great, you love your job. So with that said, phone lines are open. Questions or comments? John?
Hey, Joe. Hey, Joe.
Yeah.
Yeah, can you go back just a couple slides? I got a few good questions and comments for you there.
Okay.
You were showing maybe 2 slides or 3 slides back. You were talking about your flow rates of your retrograde cerebral. Yeah, right there. Yeah.
Yeah.
So I like this slide. By the way, that was a great review for anybody who hasn't done a circ arrest case in quite a while. Great
Thank
review.
you.
I really like a number of things on this slide. A couple I want to comment on, a couple I want to ask you about. When you do your opening perfusion flow, you actually do that initial high flow of 700 to 900. How long do you do that for?
Oh, not long. Maybe let's say a minute, maybe 30 seconds to a minute. It doesn't take that long. You just need to get that that cerebral vasculature perfusion opening pressure to get it to flow. And I learned this a lot from Dr. Garami. If you go back and look at Dr. Garami did. Yeah, he loves TCD. If you go back and look at Dr. Garami's presentations from our program, you'll find that he talks about that quite a bit. And he did a lot of work with TCD and retrograde cerebral perfusion under Dr. Safi. And Dr. Safi actually came here, was in the studio, and gave a presentation. I would welcome people to go watch that, because this is a guy that really does this operation. He did this operation all the time. He's recently retired, sadly, but you know, it is, you know, he retired. But with that said, he talks about the need for getting that opening pressure there and then backing off. And so that's where this is coming from.
So when you say there drive pressure between 60 and 70, where are you measuring that pressure from?
That's we put a lower lock right there at the cannula, the connector of the cannula.
Oh,
that's a line
okay.
pressure.
So it's sort of your line pressure, but very close to the patient.
Yes.
Line pressure.
Yeah, it's a 22
okay.
French. It's a 22 French catheter. It's going to have. It's not going to have a whole lot of additional resistance.
Yeah. Well, I didn't know if it was monitored way back closer to the pump, or if you had some type of catheter in the SVC that you were using. I was just curious about that.
No, that's such a that is such a good question.
You know
let me just.
Go ahead.
Here, wait, John, before you go any further, let me say that, because that was a very good point. What I like to do is take that line, if there's a lower lock on it, put the monitoring line. It goes to anesthesia, so I can see it on the monitor. I want it to be a zeroed line that I know I can rely on that pressure, and I want to be able to watch that line throughout the course of the procedure. So that's the technique that I use. I didn't put that in here, but since you brought it up, I wanted to make that point, because it's an important point.
And another thing, so you know what's surprising, and you touched on this a couple times earlier in the lecture, but I want you to stay on this slide though for that. And that is, we noticed the same thing back in the day when we first started doing retrograde cardioplegia. It was really surprising how dark the surgeons would see that blood coming back up through the coronary arteries. And I suspect your comment with regard to this has to do with that same thing. Even though you haven't been circ arrested very long, you circ arrested, it probably wasn't but a few minutes or so before you got the retrograde cerebral perfusion up and running. Right. And next thing you know, it's really dark what comes back through those carotids, correct?
Absolutely. Absolutely. Yeah. Absolutely. You're 100% correct. And we continue to see, even at 18-degree perfusate temperature, the blood going in at 18, we continue to see a relatively easy color difference throughout the course of the procedure. Now, the first short period of time, it is dramatic, but it does improve. It just looks more normal. Maybe it's a little bit brighter than what you would see, for somebody who's just walking around like I am now. But there's a definitive color difference, and there's no doubt in my mind that there is oxygen being extracted by that brain at 18 degrees.
And that's got to be reassuring that it's actually occurring at that cold of a temperature. The other thing I would comment is the thought, and I've been asked this before, well, doesn't some of the blood, when you're doing this retrograde cerebral, the way you're doing it up the SVC, doesn't some of this blood go down the arm? And the answer to that is no, because of the valves that are in your arms. Fortunately, your one-way valves in your veins.
Correct. Yeah, that is correct.
So you don't need to. Now that brings me to my other point, which was you did show a little bit on cannulating the axillary artery. I don't know if you've ever done an entire perfusion run by cannulating through the axillary artery, and I have, and it was very, very high pressures that we had to run
Mm-hmm.
for whatever particular reason.
Well,
I don't know if you've ever experienced that.
Yeah, John, and I think you're 100% right. I know there's a debate about whether or not the brain is adequately perfused, retrograde, or if it's superior through its normal circulatory route. So, from my point of my thinking is it isn't normal if only one head vessel or the right carotid is being perfused. So that's not normal because the left is normally perfused also, right? The innominate gets perfused, the right carotid, and the left carotid, and the left subclavian. So we're only going to perfuse one. So to say it's more natural, more normal, is counterintuitive to me. There's nothing normal about this. It'd be like me going in and just clamping one of your carotids off. I don't think you're going to be very happy with me if I do that. But then to understand that 46% of the population, more female than male, by the way, have an incomplete circle of Willis, one that is not truly functional. And the people that did that research state unequivocally that if you're going to use single arch vessel cannulation, axillary cannulation to perfuse the brain and depend on the circle of Willis, you need something else besides that. I mean, I don't think you can be more clear. So retrograde, to me, it reduces the embolic risk, it flushes it out. It's proven by people who are recognized worldwide, and that is Dr. Safi and Dr. Estrella. I mean, they are both recognized around the globe as being truly expert aortic surgeons, that they use retrograde for these very reasons. I'm going to listen to somebody like that. I'm not going to listen to somebody who just does 200 cabbages a year and one of these a year. I want to talk to the guy who does this every day. That's what I want to follow.
Well, I'm making a comment and asking you a question at the same time. If you do it the way you demonstrated with the retrograde cerebral perfusion up the SVC, you're pretty much guaranteed that your retrograde venous flow is going to get everywhere, regardless of the patient's anatomy, right? Because you don't have to worry as much about a missing branch or part of the circle of Willis, because the venous blood supply is going to go to the capillaries, and it's going to have to find its way back down to the carotids. Whereas opposed to the other way around, and you're only doing one carotid, you may be missing out on something.
Absolutely.
Is that correct?
Absolutely. And still see blood coming down the contralateral carotid. Doesn't mean that because you could have one side or the other that's incomplete. So you don't really know. And how do you assess that? You're sort of looking at it. It's kind of a guess at that point in time. I would again refer you back to Dr. Garami, Zolt Garami. You can look him up online. Great guy, super, incredibly knowledgeable on TCD. If we do retrograde and use TCD, you can literally see both middle cerebral arteries flowing. So if you're flowing both middle cerebral arteries, they're flowing, obviously opposite direction of what is normal, but they're flowing backwards, but there's flow in them, you know you're okay. How do you not know how would you think otherwise?
Let me ask you this. You didn't touch on this, I don't believe, but I remember, so many years ago when we were doing this, a couple things. Number one, I think a lot of people think to themselves, if I'm doing any retrograde or even antegrade cerebral perfusion at all, I'm a lot better off than we were when we were just doing circ arrest without it. I think I've heard that kind of approach before, but I think that idea is dying off a little bit for the reasons you said. But my question was, 2 or 3 minutes before you go to circ arrest, are you making the patient alkalotic?
That's a really good question, and the answer to that is no. That's a great question. No, I'm not. I just am I get my acid base at exactly where I want it to be, and that's where I go. I don't make them alkalotic.
But I think it's relatively, I think a lot of people probably do, right? I mean, I was speaking with somebody about this the other day, and they make them a little bit alkalotic before they, 2-minute warning. We used to have what we called 2-minute warning. The surgeon would say, okay, 2 minutes. I would go ahead and get the patient. At that point, I would go ahead and hyperventilate, give some bicarb, and then, we knew we were going to get acidotic, right? Because we were going to have a 45-minute circ arrest back in this particular surgeon I worked with, and so we would do that. But I just wonder nowadays, do people still approach it that way?
Well, I mean, not for me. In the cases that I do, of course, we're looking at usually a 20 to 30 minute circ arrest time, because they're just going to do that distal anastomosis, as I talked about. I never really spent time doing big aortic surgeries, so it's not my thing. Yeah, I'll be right there, promise. We got a caller, so I want to make sure we get them. But I want to answer your question first. So, I think that, an amp of bicarb, or even a 2 amps of bicarb, and breathing off some CO2, I think that's counterintuitive to blow off the CO2. I don't think that's a smart thing to do at all, because I think CO2 is going to constrict cerebral blood flow, and when you drop it like that, so I don't think that makes sense. I think making them more alkalotic shifts the oxyhemoglobin dissociation curve and reduces the oxygen release to the tissue, which I don't want to compromise. So for me, I don't think that makes sense, but there could be good reason for it for people who do longer circ arrest times. I'm talking 20 to 30 minutes, and sometimes even less than that. We spend way more time cooling and way more time warming, but these people leave looking like my snowman with a smile on their face and not out of a pine box. So I'm happy with that. If that answers your question.
But go ahead and take your call. Be interested to see what the caller says.
Yes, sir. You're on the air, or ma'am?
Yes, this is not ma'am, but I heard my name on Facebook. This is
Hey, Dr. Garami. Dr. Garami just called. So talk to us, Doc.
Yeah,
what's right?
Well, FBI just reported that my name was heard on Facebook, and I just had to call in, man.
Yeah,
congratulations for the great program. And I just wanted to add one really crucial detail with the retrograde RCP experience we had. So when TCD was showing the capillary opening pressure, I think you have to go open over like 40 mercury millimeter pressure gradient. What's the difference between arterial and venous side? So we started with, instead of 500 cc per minute, a little bit higher. We started 600, no flow. 700, no flow. 800, I see a flow. No, we can go back to 500. So I think what was crucial is that we could identify a capillary opening pressure, and after that, because we were afraid of the edema as well, that on the venous side we perfuse too much flow. So we able to bring it down to 500, and sometimes it was even less than 500. What was really crucial, I think, what we learned in the beginning, that the stupid TCD has some wall filter, and the flow sometimes was so minimal that it was really filtered out. Yes. And what we were focusing, that we'll try to flow a similar flow velocity what we saw during the cooling down part. So we could almost match on the retrograde cerebral perfusion what was we were flowing antegrade fashion. And we did very few cases with Dr. Safi and Dr. Estrella with antegrade cannulation. Another finding, I think, from the surgeon was that it was extremely busy because you have a cannula on the operating field. While do you do the retrograde cerebral perfusion, the operating is quite open. Those cannulas are not obstructing your views. And I think you mentioned, Joe, for me, the most important part is you are preventing embolization. And from the literature, what I saw the first time they used the retrograde cerebral perfusion, and in Japan, incidentally, they pumped the patient with air. And what they wanted to do is de-air the patient. This is how the retrograde cerebral perfusion was used the first time. And I thought that this is what we can show with the TCD, and I think the TCD had a good value of also after you done the operation, the proximal anastomosis, and you completed everything. During the warm-up, as you said, you don't want to do really fast warm-up because that's the hyperemia.
Yes.
So when from the cold you're warming up, I think the TCD value, what we are using today, is double the velocity. That will show hyperemia flow. So the brain is really stunned, unable to really
Auto-regulate.
auto-regulation for that flow. So the double velocity was our guidance for the warm-up, but also for the antegrade flow as well.
Very interesting.
Congratulations for your program, and I just would like to say keep educating us, because I think it's very helpful, and spread the news about TCD, because I think every operation should be monitored with TCD. And stay safe, man.
You too, sir, and thank you so much for the kindness of your call. And I agree with you, TCD is something that needs to be more in the mainstream and not something that is used only in selective academic centers. It really does need to get out into the community world, because it does bring a tremendous amount of value. I agree with you 100%. Would like to get you back on the program maybe one day.
Sure. I just need to finish my quarantine with my COVID shit, and I'll be happy to back on the podium.
Okay.
Otherwise, we can do remotely.
Well, I'm going to I'm going to have the New Orleans conference again, so I expect to see you there.
I will see you in New Orleans for sure.
All right. Bye-bye, sir. Thank you.
Bye. See you guys.
So, John, I think he answered the questions that you had, I hope. And I was wondering if, with your permission, if we could take maybe a short 2-minute break. Maybe, or how much time do we need? 6 minutes. So we're going to take, could we take a 6-minute break and then come back and do your slide deck?
That'd be perfect. That'd be great.
That'd be great. Thank you, John. Thank you so much. We'll be back in 6 minutes. Okay, so